So I have brought some X-rays. Maybe I can comment on those, and I'll ask questions to sir. All of us.
This is an interactive session basically.
Okay.
Let's have an interactive session.
Okay.
Lecture, fair enough.
So, as you know, degenerative scoliosis is a spinal deformity that is not pre-existing but develops after the onset of skeletal maturity. Any curve in the coronal plane more than 10 degree, you call it degenerative scoliosis. It's more or less a problem confined to the lumbar spine. Now we call it degenerative spinal disease than degenerative scoliosis. It's a more descriptive term. Even though the deformity is in the coronal plane, there can be imbalance in the sagittal plane. We give more emphasis to the sagittal plane problem because that's more disabling than the coronal curves. Here is a 63-year-old female. This is the X-ray and this is the clinical picture, sagittal and as well as coronal imbalance. So how to proceed further? What is the natural history of this degenerative scoliosis? So Subir, come on.
You first need to do bending films to see how much correctability.
Okay, sir.
Osteoporosis workup,
Osteoporosis, yes.
and then your
Draw
draw your
regarding any stenosis, is there any claudication in this patient?
Yeah.
Wherein that would you allow me to think that whether this patient may need some decompression at so and so levels. So an MRI, obviously axials would be the one that would tell me the most.
Yeah.
Flexion extension films, the exam scans,
Okay.
all these would be indicated to evaluate the patient properly. Because, and then come to a plan as to how much to plan and what are the potential of this.
Yeah.
yeah, this-
Sir, more comments from you?
That's it, from investigation point of view.
sagittal parameters.
Yeah.
That's the planning thing basically.
Yeah. So her sagittal parameter is moderate or very positive, positive or very positive. If the vertical line from C7 down, if it falls off the posterior superior corner of S1, if it is more than 9.5 centimeter, it is very positive sagittal barons, global barons. If it is between 4 centimeter and 9.5 centimeter is moderate, and up to 4 centimeter it is normal. So, and there is some thoracic curve also. So we discuss one by one about the natural history. If what happens if we don't do anything.
Will further fall off, stenosis will be a problem, osteoporosis will be a problem.
And what about the reasons? Is there any genetic predisposition to the development of degenerative scoliosis? Some publications are there that shows there is expression of degenerative spinal disease is supported by the various typical copy number variation associated structural variants of the genome. So there is a genetic predisposition. And then how to position most of these patients, because of the sagittal imbalance, they will have compensatory mechanisms like hyperkyphosis or hyperlordosis of the spine above, then flexion of the hips and knees, or hyperextension of the hips followed by secondary flexion. So there may be limb length discrepancies. So how to position these patients so that you get a correct idea about what is the actual deformity. The main thing is you have to abolish the knee flexion, keep the patient in the fully extended position, use blocks so that the limb length discrepancy is avoided, keep the hip in normal position, and with the patient erect like this, the upper limbs pointing towards the supraclavicular fossa. So in that position you have to take the lateral position and fully weight bearing anterior posterior full length spine from at least the C7 to both hips. And what about the risk of progression? there are different papers suggesting different things. This is one paper that shows it is more progressive in women more than the age, and lateral listhesis of the lateral subluxation of the spine, and scoliosis to the left. But even then they say that the small curves also can progress and should be individualized. But there is another paper that says there is no correlation for age, sex, osteoporosis, directional scoliosis, listhesis. All this did not correlate with curve progression. But they concentrate more on the intercrustal line, whether the position of the L5. If it is below the intercrustal line, if it is more deep seated, the chance of progression is high. Moreover, if the apex, the disc spaces, the bending of the disc spaces above and below the apical vertebra, if it is more asymmetrical, the chance of progression is more. And if the rotation of the apical vertebra is more, then also the chances of progression of these curves is more. And there is one paper showing that there is the decreased sleep also can cause progression of the degenerative scoliosis because of the interaction of glucocorticoids and interaction of interleukin 1. So classification. Comments, sir? We need a classification so that we are speaking the common language and to assess. And there are different classifications. I have quoted one, the Schwab Spine Deformity Study Group classification, which is easier. Then there is SRS Adult Deformity Classification, but I found it the Schwab SDSG classification more easy because the type 1 is only thoracic curve. Then type 2 is upper thoracic major. The apex is from T4 to T8. And the type 3 is lower thoracic major. The apex is from T9 to 10. And type 4 is thoracolumbar major curve, T11 to L1, and the lumbar curve, L2 to L4, and a K. There is the deformity in the sagittal plane. Then there are modifiers. The sagittal cope, if the lordosis is, that is more important, the sagittal profile. If the lumbar lordosis is marked, it is A. If it is between 0 to 40 degrees, it is moderate lordosis, and C is no lordosis. No lordosis is more problem. Then subluxation modifier, that there is lateral subluxation of the vertebrae. There is 0 if there is no subluxation, 1 plus if subluxation is 1 to 6 millimeters, and 2 plus if there is subluxation of more than 7 millimeters. And the global balance modifier, if I have mentioned earlier, is a normal 0 to 4 centimeter. If the C7 to posterior superior corner of S1 offset is more than up to 4 to 9.5 centimeter is positive, and more than 9.5 centimeter it is very positive. So about the treatment.
Always conservative first.
Okay. What all measures can we do for conservative?
I would initially try with wood blocks and also do selective decompressions in these elderly ladies with gross deformities. If I can get away with a significant amount of relief in the leg pain. Back pain, no matter whatever surgery we do, is still going to be somewhat painful despite the best of fusion. But yes, if it is getting a problem into her chest and she's getting a lot of rib pain, then yes, fixation right up to the lower thoracolumbar junction T10, T11 would be indicated for the lumbar degenerative.
So what's your protocol, sir?
I usually go slow.
Conservative?
Absolutely conservative is the start. If they are not responding, then the next step would be to a local, as we said, a local decompression.
And when do you prefer surgical treatment? In what sort of patients?
Everything fails when there is incapacitating pain, this is not work, and so we need a fixation and stabilization. These are also floating patients, and then the typical failure starts. You go up to T11, and that becomes when you get proximal kyphosis, then you go higher up, or you go to T7.
Yeah, the indications for
Decide about the local decompression, which levels
MRI and corresponding with your clinical
Clinical
findings.
examination.
Clinical findings and MRI suggest if it is L4, L45 or L5S1, then you go ahead.
You should always try facet blocks and other things first. That gives best result in these patients. Roadblocks
Selective
and
selective roadblock.
Yeah.
Do an L3, do an L4, after a few days, do an L5. Just with xylocaine. Do not put a steroid. And then the patient will be able to tell you that, okay, that one gave me the best thing. So that is the one that needs to be decompressed, if it will be thinking.
So the chances of, there are papers showing the chances of progression in lumbar curves if it is more than 30 to 40 degrees and more than 6 millimeters of olisthesis, lateral subluxation, and the curve progression, progressive neurological deficit, progression of the subluxation, and increase in clinical symptomatology. You have to assess this, and regarding the outcome and the indications of surgery, some papers say that in young adults, if the thoracic curves also increases along with the lumbar and the pain is not resolved by conservative measures and the deformity is unacceptable to the patient, then you can choose surgery. And older patients, if the documented progression with coronal or sagittal imbalance and if their ambulation is labored and or there is back or radicular pain or symptoms of spinal stenosis associated with the lumbar curves and significant loss of pulmonary function not attributable to the underlying pulmonary disease. There are different treatment options as Sir and Subir has told. There can be decompression alone, then decompression plus fusion, then anterior or posterior, then along with osteotomy and all those. But you have to select the patients depending on their problem and how much severe is the scoliosis and the disability because of that. That sagittal profile is very important. For if the sagittal profile is impaired, a single stage posterior correction with, if the curve is less than 70 degree, with radical facetectomies and rib osteotomies can be performed. If there is more severe and rigid curves, then you can do an anterior release plus posterior, or you can do osteotomies so that you get a normal sagittal balance. If a single procedure causes more bleeding or if it's not safe, then you can stage the procedure. And the complications, if you do a long fusion from T1, T3 to sacrum, then chances of complications are more compared to the shorter fusions where you can get away with proximal junctional kyphosis and things, smaller complications. But pseudarthrosis is more in when you fuse the long term. And all these complications and the poor purchase of screws because of osteoporosis, all are there. So the outcome, who benefits from the surgery? The maximum benefit after surgery for patients without lordosis. Those who have loss of sagittal profile, if you correct a normal sagittal profile, then they get maximum out of the surgery. If there is more lateral subluxation, if you correct with anterior surgery or posterior, then they get improvement in their health related quality of life assessments. And patients with imbalance, sagittal imbalance, they require osteotomy, whether from posterior, pedicle subtraction. If it is severe rigid one, you can do a vertebral collar resection and correction. And global balance, if it is very positive, that is more than 9.5 centimeter, they need osteotomies and correction. But if you do these type of surgeries, extensive surgeries for patients with normal sagittal balance, they may not be happy in the long run. So in those patients, we can continue with conservative treatment or smaller procedures when there is localized stenosis, just address that, or local decompression and fusion at that area only. With the normal profile, sagittal profile, then you can do that. If the normal sagittal profile is not there, then you can go with more aggressive surgeries. So you can select the patients accordingly. I think it is clear now. So patients who improve after surgery, they have a low baseline health related quality of life assessment scores and a high baseline classification scores like very positive, high lateral subluxation, and the lumbar modifier with the lack of lordosis, that is C. Then you can use your osteotomies to correct this, and if there is significant sagittal imbalance, always fuse to the sacrum. Otherwise, they will follow further and cause bad results.
Even, I'd like to just add at this point, even if anybody is planning to do a fixation, say L2 to L5, don't stop at L5. Go to S1 and do an interbody fusion at L5.
Yes.
Otherwise, your L5 S1, if you leave it mobile on top of it, which is like a 4-level fixation, it will fail.
It will fail.
You have to go to sacrum. Otherwise, you are doomed and will have a serious failure.
Sir, any other comments from?
Ideally interbody, because posterior fusion sometimes is not sufficient. You don't get such a good fusion mass posteriorly as compared to what you get if you do an interbody. With an interbody, the graft is at a compression, you get a good solid fusion, and cerebral purchase, even if they are bicortical, they still will not be as good as a lumbar pedicle, because it's a very wide area in which a screw is being set. So that's why it's better always to work interbody and
Most of us here do not go into the ILM, so we need a good interbody fusion. Actually, say the site is on 2 that will fixation also. But if you go into the ILM and when the ILM is blue, then you don't need to, if you have gone away from doing it. Go into the ILM, you don't need to go into get do an interbody.
what should be the upper levels.
You should not stop at L1 and T12. You should always go up to L1.
T10.
Very the highest, very highest of you should go up to
So this is another lady, very severely osteoporotic, very difficult to, very labored ambulation. So can you offer anything for this patient? Your suggestions?
First you treat the osteoporosis first.
Yeah.
osteoporosis, MRI, where's the MRI?
So the problem is that if you do the surgery, then she will keep on reporting you every day.
Yeah,
It's better to avoid
severely
it.
osteoporotic and some compression fractures also. So she didn't opt for any surgery, she went on for conservative.
There is one sort of thing that I sort of gives feedback, that what is the demand of the patient? Is this patient really demanding? This lady, is she going to really be like, I want to do this? No, probably. So that demand is the feel factor that you tend to get from the patient, that how much you should be aggressive in this case and how much you should be conservative in this case. There's no textbook criteria, but it's just a feel that you get from the patient, talking to the patient.
And also the general condition of the patient, whether she will be able to tolerate
That comes secondary. That comes after you ask the medical history. By talking to them, it's not much care.
Yeah, it is very tempting to see these curves, this imbalance, all these problems are there. You have been and good to a good fusion here and there, but they come very, very miserable. So there's a difference between our patients, like we said, and what is happening in the West. The Western elderlies are totally on their own. They have no support at all. They have to be totally on their own. So they need help. They need, thing. Here, our patients are very, very
Well supported.
well supported, and they also are able to discipline and accept, old age and disability. So they don't have to go for skiing. They don't have to even go to the mall. If they are happy just walking up to the puja room and the family room, they are happy. And if you consider that satisfaction and the support of the family, vis-a-vis operating them, get good radiological direction, and making them miserably, as Abrar said, osteoporosis not taken care of. Every 2 years, even less than that, 6 months, you'll come up with the pull-out screws and the out of
A lot of problems, lot of problems.
Infections, malnutrition. I mean, are you really justified? Let them be, you know. So like
Well, bracing
Subir
is-
said, you know, let them adjust their life. They have support. So,
Treat the
Raising-
patient, not the ex.
exactly.
Treat the patient, not the ex.
And talk to them. Talk to them in our staff, and you talk to the family which we are the patient. Having said that, you know, 5 years. I mean, things are becoming more aggressive now. The patients do demand a better quality of life. They are coming now. So we have now moved on to conservative decompression and things like that. And maybe after about 10 years down the line in the bigger city, a group of patients will come and you will have to do what the West is doing.
The bracing, we have not seen anybody. It's very difficult for them to wear the brace because it's more suffocating, breathing difficulty because they have large tummy, everything. It's very difficult to wear also.
The bracing gives them a lot of psychological support also.
If it's a small belt.
So there are times when, you know, when they pain, you give them a belt and, you know, they're fine, you know.
Not a cumbersome one.
Yeah. Small LS corset, but even though it doesn't help anyway,
Basically,
but
the
psychologically
psychological
support.
belt is quite loose, but still the patient is happy.
Patients are happy.
And something is being done, you know, so it's not a bad idea to sort of say.
And many of them say, when I put a LS corset, I'm very much relieved. Even though it doesn't help anyway. Here is a sagittal as well as coronal imbalance for this patient. Somebody did surgery twice. They attempted screws, but the patient was told it was not possible to put the screws. So the patient is on wheelchair.
Is license or is it
I think it had a
idiopathic license?
Iatrogenic lysis, laminectomy.
And then L3 goes left, you know, I think.
So laminectomy there. Laminectomy. Somebody did laminectomy. Yeah, I have. MRI. This is MRI. The patient on wheelchair. Oh, it's a AP. This is laminectomy done by somebody else. The only one fault is I have stopped at L1, not D12. It's one drawback.
Up to now.
Yeah, I have gone to D12, but the problem, what happened is the day after surgery, she developed a CVA, thalamic infarct. Now, then she continued to be on wheelchair for another 4 months. Now she started walking. She has improved.
But you use 2 rods, you see.
2 rods because it was very,
Double rod.
yeah, double rod, yeah,
Double rod on either side.
yeah.
So you first align your...
First arrange the other things and then put.
So the proximal 2 screws have 2 rods.
No,
on either
no.
No.
He is lacking connectors.
See, the proximal 2 screws and the distal screws I connected with 1 rod, and the deeper one, all 3 I have connected with another 2 rods.
Did you use a dominoes to connect the 2 rods?
Cross links I didn't use. I could have.
No, dominoes.
Can you do that?
No.
On one side, like if you have, you know,
No dominoes, sir.
so you need to connect both the rods, otherwise it will not serve.
Otherwise,
Otherwise it will continue to fall off, so
Okay.
maybe 2, 3, 4 will continue to go forward, you know. You're linking the S1.
I did an interbody fusion also.
But lower down, no?
The max,
3, 4 is not to be more.
this area 3-4 I did an interbody fusion.
Okay.
The other one looks almost in connection.
What is dominoes rods?
To interconnect the rods.
Side
Yeah.
to side and then
Side to side.
So if you're having problems,
external fixator
if you're having
where
problems,
which has
yeah,
been rods
yeah,
going
yeah,
in.
yeah. So if you have problems getting a single rod in complex problems, you can use 2, 3 rods, but one thing is to make it point, like you said, as you would use in radial or just make them together, so stability increases.
Under a 65-year-old man with severe radicular pain and relieved by rest. What to do? On ambulation he is having severe pain, radicular pain.
an existing deformity, say it will take off.
Yeah, yes. With the degeneration, with the lateral subluxation also. Yeah, I did know, yes.
Type of
Yes.
deformity is,
Yeah.
and because probably a portion of it, the sacral the agenesis there, the vertical thing.
Yeah.
Don't try correctly, because there are certain parameters is already
Yeah.
Selective nerve root block.
Lateral subluxation, all those.
and it will ever be.
So I did only a local decompression and fusion, not the correct the entire curve. So he was symptom relieved. Yeah.
They said more patients.
Yeah. No, she is not ready for anything, but this is the thing. Even she is walking very, I just wanted to show you. She's walking and doing all sorts of household job.
The planters are going.
See?
Are the planters are going?
No, nothing, sir.
Don't touch these. You'll
Yes,
go
it's very severely osteoporotic.
The power bladder will also go. And
So any questions? Any other questions?
Thank you, Dr. Pillai. Excellent talk. Next. No, I think next.
Dr. Subir?
Dr. Subir will talk.
Good afternoon, everybody. Obviously, this is one of the very complex deformities that perhaps this is probably one of the most horrendous deformities that I would probably want to even think of. That these are the kind of things, these are the kind of patients that you probably want to send to your enemy and your colleague who's working in your same area, and then make sure that he operates these cases. These are those cases. I'll just show a quick case of mine. This was an 18-month-old child when he had suddenly developed some weakness of the foot and presented to me with a T1-2 abscess, epidural abscess, cord compression. An 18-month-old child, I got hold of a pediatric pediatric general surgeon to help me open the chest. This is the kid at the time of surgery. We went in, did a decompression and put in a rib graft. That's the rib graft there. At that time I braced him up. He recovered. But then obviously, as expected, he began to gradually show increasing deformity over here. He became ambulatory, fortunately, but the deformity gradually kept on increasing. Then I went in and did a posterior fusion surgery also to make sure that the posterior elements, which otherwise if they continue to grow, the deformity would also continue to grow. So I attempted that and fused him from C7 to T4 posteriorly also, in a hope to arrest the further progression of the deformity. And he's probably stable at about 80 degrees. This is the co-op probably would be around 80 degrees. Right now he is stable at 80 degrees. He's about 3.5-4 years out right now. I don't know probably when I'll probably need to go in again and do a classic osteotomy and things like that. But this is just to set the ball rolling for the pediatric tuberculous deformity that we tend to get. We all know that TB usually heals with some degree of collapse, and the adults, it's only the untreated cases, and they never really go to the kind of the huge deformities that we tend to see in some kids. But in the children, it is not only the active disease that leads to deformity, it is also the healed disease, and especially after a brief lag period, following which there is a differential growth between the front end of the spine and the back end of the spine, which tends to lead to these grotesque deformities. A very classic article by Rajsekharan in the JBJS 2001 wherein he looked at about 61 patients over a period of 15 years. His initial article was in 87 or something, when they looked at the Madras MRC trials, and then subsequently those children were followed up, and at 15-year follow-ups he has come out with a significant amount of information on this problem, in the sense that the deformity tends to progress in about 40% of cases, and in them there is again a small subgroup wherein the deformity progresses at the lag end, after a lag of about 3 to 5 years. In another group, he said about 40% tend to stabilize over time, and the probable reason that he quoted was that probably it is because there is a sufficient anterior contact that the vertebral body tends to get, and in a small subset the progression of the deformity is usually not seen. So he gave 4 cardinal signs in that paper, and this is actually a very good paper. If anybody has any such tuberculous deformity case, and they should probably look up this case, this article. He quoted facetal subluxation, retropulsion of the element of the vertebral body, lateral subluxation or lateral translation, and a vertebral toppling sign. So these 4 signs are the one that he gave 1 point each for these signs, and developed what is known as the spinal instability score. And that score, if you get 2 or more signs in any such case, then you can predict very well that this child is likely to develop a deformity, likely to develop more than 30 degrees, and the deformity is likely to cross 60 degrees. So this was a very important finding that came out of that paper. He also, in another article, he showed 3 basic methodology of restabilization, where if there is a wider contact, then the deformity stabilizes and there is no further progression. If there is a point contact, then the deformity is likely to progress, but not significantly. And if there is a 90-degree sagittal rotation of the upper vertebrae, wherein the vertebrae sort of comes down and hits the lower vertebrae, then that is the where he calls this a buckling collapse. And in this situation, there is actually a end plate, the lengthening of the growth actually occurs in the reverse direction, and you tend to get a longer vertebrae along the horizontal axis rather than the vertical axis. This is one of these, the paper, one of the sort of the examples given in the paper. This was a fused vertebrae, and over 15 years it has formed a stable vertebrae. And in another one, he has showed that this was about at 3 years, a 40-degree deformity has gradually increased up to 115 degrees of deformity. So over 15 years of time, this is the kind of thing that happens to the pediatric spine, which was very well documented. In another article in the spine in 1998, he has also quoted that the thoracolumbar lesions, they are the ones that tend to progress the most, followed by the thoracic spine, and then the lumbar spine tends to progress the least. Second thing is that the children between 6 to 10 years, they are the ones that are likely to progress the most, followed by the children less than 5, and those beyond 10 tend to progress the least. The vertebral body loss that is seen in children is about 1.9 times the body in children less than 15 as compared to the adults, which is about 0.96 only. So that at the time of starting of therapy. So these are the basic sort of thoughts that tend to tell us that which are the children that are likely to progress. Sorry. If we take a quick look at the adult disease, then we usually see these patients in the wet stage of the disease before the deformity has really set in. And depending upon the degree of involvement of the vertebral body, the degree of deformity that has existed, we tend to take these into whether the anterior surgery should be done or a posterior surgery should be done. Just a quick look at one case. This is a significant destruction of D9, D10, followed by a good reconstruction anterior, and this has gone on and healed well, and no posterior reconstruction was needed because it was within the thoracic spine. Had this been at the thoracolumbar junction, a 2-level vertebral reconstruction at the thoracolumbar junction cannot be allowed just an anterior reconstruction. You have to add a posterior reconstruction to this construct, because otherwise this would fail if it was at the TL junction. So that also tends to tell you that where the problem lies and how much should be done. Taking it to the next level is where we tend to see what is known as the pedicle subtraction osteotomy. This is one case where the patient had D6, D7 tuberculosis with an epidural hematoma, and she was a frail lady, about 68, 70-year-old lady, osteoporotic bone definitely, but then I was not very inclined to do an anterior job in her. So I decided to do a pedicle subtraction kind of a situation wherein I went in and did, I'm not sure about how much, I'll just quickly explain the concept of pedicle subtraction. Basically you tend to remove the pedicle, remove the pedicle of the involved vertebrae below, remove the top end of the vertebral body. This is actually the concept is derived from the deformity surgery which is being applied to infection in this case, which is why I am sort of slight change in what is actually being done in a PSO in deformity. So here what I have done is removed the disc, the lower end plate and the upper half of the infravertebral body so as to get a bone and bone contact onto the vertebral for the next. So this is a kind of a modification of a PSO, not an exact PSO.
Dr. Subir,
Yes,
what
please.
was the neurology of the patient?
She had some weakness. She definitely had some weakness. I'm not sure, it was 5 years back, but she had some weakness in her one of the legs. She did not have complete paraplegia. She was not a paraplegic. And so this is what was done. And here this is D6, and you can see the half of D7 over here. So this is D6, D5, D4, and then D8, 9, 10. The rods are a bit longer than what they should have been, but this is basically what I achieved. And you can see here D7 is half of D7 is now adherent to the lower part of D6. So this was the kind of modification of what is known as a pedicle subtraction osteotomy done in this case. If we take a look at the vertebral column resections that would be applied to the classic post-tuberculous deformities, then we just take a look at this case. Here, this is the L1 over here. It is completely wedged. This is D12. This is L2, and you can see here in the MRI, this is significantly compressed at this level. And what was done here is basically a pedicle subtraction and a total VCR. Now this is the vertebral. The entire pedicle was removed from here and from here. And then you go down in, remove the vertebral body. The fixation has been, you have to put a temporary rod is actually missing in this photograph. Otherwise, I usually put a temporary stabilizing rod as well, because the deformity tends to, toggle around. But that's missing in this photograph. And this is the post-operative fixation, 3 levels above, 3 levels below. And the lower border of D12 tends to come in close contact with L2. There is definitely going to be some amount of spinal cord kinking, because if you compress so much, the spinal cord is likely to kink, and you need to use contoured rods in a gentle manner so as to get this kind of compression. One tends to be lucky if the patient is able to move the legs right away, because sometimes what happens is there is a delayed neurology, 6-12 hours the patient doesn't move, and then then you start seeing the movement next day. So this is the post-operative CT scan. There is a good fusion over here. In this case, there is a little bit of a gap is still visible here, but then the patient is doing well. Now another article by Rajsekar, and this is the third variety of surgery that is possible. Now, as I discussed, PSO, then there is VCR, and then there is another option is known as the closing opening wedge kind of an osteotomy. So his discussion is basically that whenever you do an only anterior job for this kind of surgery, then the spinal cord tends to be distracted and you may get spinal cord problems. If you do an all posterior job, then there is going to be kinking of the spinal cord and you are going to get problems. So what he has been recommending, although this is not the first time that anybody has recommended a closing opening wedge for this kind of a problem, it has been described previously, but a recent article by him, so and good graphics actually, that is why I brought up this paper. And there's a very good, what they recommend is that once you start seeing that now beyond a certain stage of compression, then you should not go further, and that is when you measure the graft size, put a cage and put in bone graft, and that is how you sort of lengthen the anterior column a little bit and compress or shorten the posterior column a little bit, and thereby get a midway in between for both the columns. So accordingly, I've got, these are the classic, these are the same from the same paper I have taken these pictures. This is what he recommends: putting in screws first, temporary stabilizing rod, decompress here, change the stabilizing rod to opposite side, do the decompression and the vertebral resection from that side, and then start burying, making sure that you leave a definite cortical shell at the posterior end. It's very important to leave it there, because if you start from there, then you're going to get a lot of venous oozing, and also the cord will start decompressing, to start ballooning, and you're likely to injure it. So it is very important to just start from beneath, from the sides, go inferiorly. Once you have decompressed and removed most of the bone, and that is when you use your reverse angled curettes and break down that wall at the very end. And the third thing is that what he recommended was that once you start compressing the deformity, that is when you start looking for the cord kinking and what is also known as the concertina collapse of the concertina ballooning of the cord. The moment you start seeing, that is when they stop, and then they measure the gap, put in a cage with bone graft, and again just compress it gently so that the cage is held snug. So that is basically the kind of thing. This is his case. I have just taken it from his paper. You can see this is the deformity that they have removed, and once the deformity is removed, a cage has been put in, and these are the screws that they have come up with.
Dr. Subir, what is the timing of your surgery in this particular case?
This case was not mine, to be very
but
frank.
Case
but
if
in case if
like
I
this,
did,
what would be your what would be the timing of your surgery?
the timing would be, first is to make sure that the child has finished his growth. That is the first and foremost thing, because if he continues to grow, that is one. Two, second thing is neurology. If he is already showing what sir was asking, whether his planters are upgoing, whether his jerks are brisk, then you don't wait. You have to get in, otherwise he is going to become a paraplegic, and then you operate, there's no fun. Okay, so if you are, I usually tend to get these patients in every 6 months if I am following them up for deformity surgery. That okay, are you clinical now? Do you want to go? And second thing is obviously their vacation timings. If you can pull them till April, when the school goes in for vacation, they are stable, conservative, no problem. Then you can make, because he is going to need 3 months of school. If he is going to be around like a 15-year-old kid, he is in the 10th standard, right? And in 10th standard, then he probably needs 3 months off, and he is studying. Then that is one. Obviously, the first thing is neurology. Second thing is maturity. Third thing is school. Certain things obviously take more priority over the others. And there is a significant risk of neurological injury in this kind of kyphosis. Now, the reason, there is not only that you tend to injure the cord, but it is also the blood flow to the cord that is very important. Initially, people have been recommending hypotensive anesthesia, but the spinal cord blood flow needs to be kept at a very beyond at least an 85 MAP. Mean arterial pressure has to be more than 85. Otherwise, if it falls below that, then the spinal cord ischemia sets in, and it is already a tenuously stretched cord. So in such a stretched cord, if you want to do surgery, then you would make sure that there is sufficient the blood flow, the blood pressure should be maintained. Second thing is kyphosis. Even if you just do a positioning of the patient, those who have neuromonitoring may have noted that just after positioning only, the neuromonitoring, the leg signals tends to go away, because of the position, the cord gets stretched and you get a weakness in the lower limbs. So positioning, even releasing the tense musculature would tend to give paraparesis to these patients. So be very careful whenever these cases are being taken up, because these are the most likely to the highest risk of getting a complete paraparesis or paraplegia following this kyphosis surgery. Significant blood loss if you're doing a bilateral VCR kind of a surgery, up to 5 liters of loss has been reported in these patients. So although Rajsekhar's paper quotes something around 800 and something, but in most cases you tend to have a liter or and a half easy blood flow from these cases. So make sure you have sufficient blood transfusions available in your theatre. Obviously, loss of corrections, infections, pseudoarthrosis, there are multiple complications possible and chest complications. Most cases do not need a chest tube, but in case if you have punctured the pleura while trying to separate it, then you probably might need a chest tube. So in short, the best treatment is to prevent this deformity from happening if we can. Follow the basic principles, re-establish the integrity of the spinal columns, ensuring the stability. Be aware of the global sagittal profile as well of the patient, and be careful of the neural manipulation. Thank you.
Topic is open for discussion. Thank you, Dr. Javeri, for a
Thank you.
very didactic lecture. I'll now request Dr. Abrar to please give his lecture.
Basically, we are going to talk about high-grade spondylolisthesis, and the topic which was given to me was whether we should do a partial versus complete reduction. I don't think the topic should be whether we should reduce at all or do not reduce this sort of deformities. So basically, high-grade listhesis means there is more than 50% of slip of the capsular vertebra or the caudal vertebra, and majority of these these problems, they happen in high-grade high-grade lumbosacral dysplasia. So must know what is high-grade dysplasia and what is the difference between the high-grade dysplasia and low-grade dysplasia. So if we carefully look at the X-ray, in case of high-grade dysplasia, there may be absent or small transverse processes. There may be associated laminar dysplasia, means there may be spina bifida or absence of lamina. There may be pars defect, pedicles may be dysplastic, sacrum may be dome shaped, and the disc space may be reduced. So basically there's all 5 or 6 criteria which you should always take into consideration while defining what is low grade dysplasia and what is high grade dysplasia. So there is a new classification of this dysplasias. That's how you there are certain criteria by which you define whether the dysplasia is a low grade dysplasia or high grade dysplasia. So in laminar dysplasia, you look for the normal lamina. If it is a normal lamina, then scoring is 0. If the patient has got associated spina bifida occulta, then the score given is 1. And if the lamina is they are absent, then the score given is 2. Similarly, there are facetal dysplasia. If there are normal facets or hypoplastic facets or aplastic facets, for aplastic facet the score is higher. Similarly, you compare the transverse processes of L5 with that of the transverse processes of the L4 vertebra. If they are equal, then the score is 0. If it is smaller than L4, then the score is 1. And if it is almost absent, the score given is 2. And then you have to look for the lumbar index, that is the anterior height of the L5 vertebra. Then you compare that thing with the posterior height of the L5 vertebra and take out a ratio. And if ratio is less than 0.8, then the lumbar index score is given 2. Similarly, look for the L5 disc height and compare that disc height with the L4 disc height. And if it is less than 25%, then you give a score of 2. And then you look for the sacral slope, whether there is no slope or there is a minimal slope or there is a dome-shaped sacrum. So total score is 0 to 12. For mild dysplasia, the score given is 0 to 4. For moderate dysplasia, score is 5 to 8. And for severe dysplasia, score should be more than 8. So this is the picture taken from the article. Now coming to clinical presentation, basically the patient may present with the characteristic pelvic waddling gait. Because of sagittal imbalance, there may be flexion at the hip and knee. Patient may have flat buttock, that is called sweetheart's pelvis sign. There may be trunk shortening, the ribs may touch the iliac crest. And patients which are most at risk are those who have got the slip angle of more than 45 degrees. So these are the all pictures taken from. Basically, this is the work of Professor Jaiswal. They are taken from his this presentation. So there is a example of a patient, 15-year-old male patient, presenting with the claudication pain. Pain start after standing for 2 minutes, and the patient is in crouching gait. So anyone, any comments? What you would like to do? Anyone? And this patient. Would you like to do reduction? And before that? I mean, any further investigation you like to see whether it's a will you include L4 into it or L5 into it, or you just L5S1 stabilization only, or you like to include L4 into it?
If you want using the reductions tool, then you need to do L4 also.
Otherwise, you just L5S1.
Still need L. You have to have L4. There is no way you can not have L. If you don't have L4, it will fall off again.
So, in a high-grade slip, there is a progressive slip with sacral retroversion. As you see, these are taken from an article. As the slip is increasing, the sacrum is becoming more and more vertical, and ultimately the L5 is falling in front of the, and that is called the lumbosacral kyphosis, or the or the reversal of the lumbar lordosis at the L5S1 level. So, coming to the biomechanics of listhesis. So, there is a compensation. Compensation is by extension of sacrum, and that can lead to hamstring spasm. There will be hyperlordosis above that level, and the consequences may be there may be canal stenosis at L5S1 level. There may be radiculopathy because of nerve root stretching, hamstring spasm. There is a cosmetic problem and mechanical back pain. Now, coming to the risk factor of progression of spondylolisthesis, one of the most important risk factors is growth spurt. If slip percentage is more than 50 degree, or the slip angle, which is normally lordos, becomes the kyphos. If slip angle is more than 35 degree, then the chances of progression of deformity is much more. Basically, you look at the X-rays, and if you see the sacrum is becoming more and more vertical, definitely that there is a significantly high risk of progression of that deformity. So nowadays you have to take into account all these pelvic parameters, that is the pelvic tilt and sacral slope and pelvic morphology, and then you compare that morphology, then you take the compare that thing with the sagittal parameters, and accordingly then decide whether it is a high grade slip or low grade slip. So there are normal values for pelvic incidence. Pelvic incidence basically is fixed for every person, is a basic pelvic morphology, which is different for each and every patient. We have got different now, depending on that, if the patient has got significant with the pelvic tilt is pelvic incidence is more, then you have more chances of that deformity getting compensated. But if the patient has got less pelvic incidence, the chances of getting compensation by tilting the pelvis by tilting the pelvis is much less. So for a given asymptomatic individual, normally has got low pelvic tilt and high sacral slope. So he has got a reserve for compensating the positive sagittal balance by increasing the pelvic tilt. That is called pelvic retroversion. Now, further biomechanics of the this thing, if you draw as C7 plumb line, normally it falls very in front, quite in front of the L5 vertebrae. So in high grade listhesis, it passes far anteriorly, and there is a sagittal imbalance. Sorry, so this is again. Now there is a new classification of high grade spondylolisthesis that has been given by Haskell et al. Basically, we have to see whether the pelvis is balanced or is it unbalanced pelvis. In the balanced pelvis, there will be low pelvic tilt and high sacral slope. While in unbalanced pelvis, there will be high pelvic tilt and low sacral slope. So, as an example of the balanced pelvis as compared to the unbalanced. So basically, if you compare both the diagrams, you see the pelvis. This sacrum is vertical in unbalanced pelvis, and sacrum is normal looking in the balanced pelvis. So that is the basic difference between the two. So there is a new concept that is called severity index, and that's how you decide whether this is a high grade listhesis. Second thing, whether you want to include L4 into your surgery or not. So basically, there are two types of forces. One is the gravitational forces that is passing in front of the sacrum, and the ground direction force that is passing through the head of the femur. Normally, if you draw a line and the lateral X-ray, both lines they coincide with each other. There is a very little difference. So you draw a line from the L5 vertebrae, and second you draw a vertical line from the center of the head of the femur. Normally there is a very little difference. Then you draw a line basically from the S2 vertebra, and you connect these lines, and then you see what is the, then you take out a ratio of these things. That is the distance D1, that is the distance D1 and D2. Basically, you take the distance from the center of second sacral vertebra to the line of gravity, that is D1, and second line you draw from the head of the femur vertically upward, and that is the line that is the distance between the second central of sacral vertebra up to the vertical line from the head of the femur, and take out a ratio. If ratio is less than 20, it is a low dysplastic type of problem, but if the ratio is more than 20% is a very high dysplastic. This is because as the pelvic become more and more vertical, as the sacrum become more and vertical, the head of the femur they goes more in front, and then you draw a rectangle there. So basically, you see this difference. You draw a rectangle there. If your L4 vertebra comes in this rectangle, then you have to include that vertebra in your surgery. If it does not come into the this rectangle, then the zone is stable zone. So basically, you look for the severity index if it is more than 20 degree, and then you chart out the stable or unstable zone. So you draw a rectangle there. So you draw a rectangle there. Suppose this is a 5 centimeter between the D1 and D2. You draw a 5 centimeter rectangle. If only L5 comes into it, then you have to fuse the L5 only. But if L4 also come into that unstable zone, then you have to include the L4 also in your surgery. This is the latest classification of the this thing given by the Spinal Deformity Study Group. Now coming to surgical management of high-grade spondylolisthesis. There are different types of procedures which have been done. One is the decompression, wide laminectomy, root canal decompression. Second is stabilization, and third is the controversial whether you should reduce the thing or not, and what type of reduction should be done. Now there is a strong argument against the reduction and fixation. Large number of paper. Basically, they say if you try to reduce the thing, there is a high incidence of neurological deficit, and in fact, in the cadaveric model, it has been demonstrated by Petraco et al. That if you do the reduction more than 50%, then there is a stretching of the L5 nerve root, and that may lead to palsy. But the reduction is if you have got an old or chronic spondylolisthesis, it's just like you if you have got a dislocated head of femur which is there for a very long period of time. So if it will be very difficult to reduce because the tissues are already shortened and tissue must stretch after the reduction. So if you try to reduce a dislocated head of femur without any proper planning, then you are liable to cause femoral nerve palsy or the sciatic nerve palsy. So similar is the case here in case of high-grade spondylolisthesis. So a lot of people they started doing in situ fusion. So now the question is that why you want to do in situ fusion? Anyone will be doing in situ fusion? Sir, any in situ fusion nowadays? But you get a lot of articles where they say that they have got very good result with in situ fusion. Balanced.
The other indication is in young adults and in urgent male patients. Non-real high-grade listhesis in females and anterior and to shorten the in ways you would like to sort of not bother it.
So nowadays,
Paris pelvis and in unstable pelvis, but adolescent male up to.
so you will not like to go Italy nowadays, sir.
I do. Young girls has to
You do.
and Paris pelvis and go to GMD.
Anyone? You also doing anteriorly? No, no, only posterior. Now, why do we want to do in situ fusion? That gives good result only with the circumferential fusion. It is easy. There is no hassle. You can easily just go posteriorly, do the S1, S2 laminectomy, retract the thecal sac laterally, and then you take a reamer and you make a proper reaming there and insert a fibula there and do the posterolateral fusion. So there are many articles in the literature basically which which report very good result with the in situ fusion. But if you there's an article which are comparing in situ fusion with the reduction, and you say in this comparative analysis. There's a definitely outcome is much better in those patients in which the reduction was done, but the chances of neurological deficit is slightly higher in those patients in which the reduction was in which in situ fusion was done. There's an example. There's a Professor Jaiswal's case, grade 3 listhesis. Reduction and instrumentation has been done in this patient. Yeah, but this is basically. So coming to the reduction, will you use completely hyperextended position, or some people say that first you do the decompression in knee chest position and then you make the table straight. So what do you would like to do in high grade listhesis? Initially knee chest position or straight forward, just go backward? No, but
And then I support my the early wrist and the early spine. So they are vertical sort of pads. They are moving central. I do not normally go down to 90 degrees to sort of reduce the tension.
Dr. Sabir,
I do it in flat extension, but then once you reduce, that is when you apply pressure on the sacrum vertically down.
okay, down and then you extend.
And put 2 extra forces under the thigh to sort of, get
That tilt, that pelvic tilt.
The sacrum sort of goes down like that, put vertical pressure down onto the sacrum and hyperextend the hip.
So would you like to do a sacral corpus?
That is yes. The sacral dome has to, you need to,
Otherwise, you will not be able to do that thing. That's a very difficult thing.
The other trick is that one is with the table. The other trick is not that you have the extenders, the scoliosis extenders that you get by doing the rotation. So what we do now is to get the extenders up and